I am Dr. Rosrahayu Idras. I'm a hematology registrar from Singapore General Hospital. I'll be talking about complications of hematopoietic stem cell transplant. Hematopoietic stem cell transplant generally involves ablating patient's bone marrow and immune system with conditioning regimen, with chemotherapy with or without radiotherapy, and followed by infusion of stem cells with subsequent engraftment. There are many known complications, and they can be generally divided into early and late. Early refers to complications that can occur within the first 100 days following stem cell infusion. It refers to the pre-engraftment and the immediate post-engraftment period. Complications during this period are typically related to conditioning regimen, immunosuppression, and engraftment. Late complications are complications that happen after 100 days of stem cell infusion, which refers to post-engraftment period. Complications are generally due to continued immunosuppression and long-term effects of conditioning regimen. Here, I will be describing some of the common and important complications, such as infections, organ toxicity like hemorrhagic cystitis, cardiac failure, veno-occlusive disease, pulmonary complications, and graft versus host disease. Most of the early complications are related to the conditioning regimen. Conditioning regimen commonly consists of high-dose chemotherapy and total body irradiation, which are myeloablative and can cause significant toxicities. Recently, reduced-intensity conditioning regimen have been developed and used, which have less treatment-related toxicities. Cyclophosphamide is a common component of myeloablative conditioning regimen, of which the two major complications are cardiac toxicity and hemorrhagic toxicity. Cyclophosphamide-induced cardiac toxicity can manifest as congestive cardiac failure, arrhythmias, and rarely myocarditis, which carries high mortality. Typically, cardiac toxicity occurs during cyclophosphamide infusion or post-cyclophosphamide infusion, usually within 3 weeks. In cyclophosphamide-induced hemorrhagic cystitis, it presents with urinary urgency, spasms, bleeding, and suprapubic pain. It usually occurs in the pre-engraftment period and is caused by the cyclophosphamide metabolite acrolein. Certain viruses such as BK virus can also cause hemorrhagic cystitis, but this typically occurs later in the post-engraftment period. Another major complication that is related to the use of conditioning regimen is veno-occlusive disease in the liver. Here, there is obstruction of hepatic terminal vanules and sinusoids. Exact mechanism is not known, but is thought to begin with injury to the hepatic venous endothelium, possibly from glutathione depletion of hepatocytes by busulfan sensitizing the endothelium to the effect of cyclophosphamide. This is followed by subsequent deposition of fibrin and factor VIII within the vanular walls and sinusoids, leading to progressive vanular occlusion, producing hepatic outflow obstruction, portal hypertension, necrosis, and fibrosis of the liver. Risk factors such as pre-existing liver disease may impair metabolisms of drugs and thus predispose to endothelial cell injury. VOD is characterized by a triad of hyperbilirubinemia, weight gain, and painful hepatomegaly. Not all features may be present, and the severity of signs and symptoms can vary. Hepatic Doppler studies may support diagnosis by demonstrating reversal of portal flow. Liver biopsy is diagnostic but usually avoided due to significant morbidity. Management is supportive with careful fluid balance, use of diuretics, and defibrotide. Pulmonary complications are common in stem cell transplant. It occurs in about 60% of patients, of which 1/3 need ICU care. The pulmonary complications can be simplified by considering the time when the complication occurs. For example, diffuse alveolar hemorrhage. It is a non-infectious pulmonary complication that typically occurs within the first 2 weeks of transplantation. It presents with dyspnea, non-productive cough, and/or hypoxemia, and is associated with high mortality in view of its rapid progression. Definitive diagnosis requires bronchoscopy, which shows progressively bloodier lavage. Treatment with glucocorticoid may improve outcome. An important differential diagnosis of diffuse alveolar hemorrhage is idiopathic pulmonary syndrome. However, here bronchoscopy will not show progressively bloodier lavage. It typically occurs 30 to 50 days after transplant. It can rapidly progress with high mortality despite treatment with corticosteroids. Another common complication is infection. Transplant patients are significantly at risk of getting infections because of immunosuppression. In the pre-engraftment period following conditioning, there is a profound myelosuppression of 1 to 3 weeks until engraftment occurs. During this early period, gram-positive, gram-negative bacterial infections, Candida and Aspergillus fungal infection, herpes simplex viral infection are common. During the post-engraftment period, gram-positive bacterial infection are more common, as well as Candida, Aspergillus and CMV infection. This is due to the continued immunosuppression from GVHD and its treatment. After 100 days post-transplant, patients continue to be at risk of infection because of immune dysfunction until immune recovery occurs, usually within 12 to 24 months. During this late period, bacterial infections are commonly due to encapsulated bacteria such as pneumococcus. Fungal infection is mainly from Aspergillus. Viral infections due to varicella zoster and CMV, and protozoal infection from Pneumocystis carinii can also occur. One important viral infection to note is cytomegalovirus or CMV. Cytomegalovirus is present in 70 to 80% in general population, which reactivates and causes either asymptomatic infection or CMV disease. So having antigenemia does not necessarily equate to disease. CMV disease commonly presents as fever of unknown origin, interstitial pneumonitis or enteritis. Less often, these patients can develop retinitis, encephalitis, hepatitis, or bone marrow suppression and death. Since the introduction of prophylaxis and effective treatment using preemptive approach, incidence of CMV disease has markedly reduced. Graft versus host disease, or GVHD, is an important complication which is potentially life-threatening. It is divided into acute and chronic. Classically, acute GVHD occurs within the first 100 days post-transplant, and the classic chronic GVHD occurs more than 100 days post-transplant. Now it is recognized that there is a persistent late acute GVHD, and another subcategory that has been added to chronic GVHD, which is called an overlap syndrome, where patients have features of both acute and chronic GVHD. Pathology of GVHD begins with tissue damage by conditioning regimen. This activates the host antigen-presenting cell. The host antigen-presenting cell then interacts with donor T cell, causing subsequent donor T cell activation. The released cytokines by these stimulated T cells cause cytokine and cell-mediated damage, which cause further tissue damage. Acute GVHD occurs within the first 3 months post-transplant, although it can occur later upon tapering of immunosuppression. It occurs in 20 to 70% of patients. Acute GVHD affects skin, gut, and liver. In the skin, it presents with maculopapular rash, typically affecting the face, neck, palms, and soles. In severe cases, it can affect the whole body and progress to erythroderma and painful blisters. In the gut, it presents with nausea, vomiting, diarrhea, abdominal pain, which can be severe to cause severe pain and bloody diarrhea. In the liver, it presents with raised bilirubin and raised ALP. Commonly used grading system is the modified Seattle criteria, which has shown to correlate with overall survival. Mortality is as high as 90% in grade 4 GVHD. Prophylaxis is used in GVHD and usually consists of cyclosporin or tacrolimus with methotrexate or with mycophenolate. Treatment depends on severity of GVHD. First line is corticosteroids, in which 70% will respond. Second line treatment include extracorporeal photopheresis, mycophenolate, biologic agents such as alemtuzumab or etanercept. Chronic GVHD is the leading cause of late non-relapse death. Prevalence varies from 25 to 80% in the long-term survivors. Diagnostic signs such as poikiloderma and lichen planus in the mouth, as shown in the pictures. These are clinical features that establish the diagnosis of chronic GVHD without the need for further investigations. Distinctive signs are clinical features not associated with acute GVHD, but which would not be sufficient to make the diagnosis of chronic GVHD unless supported by positive biopsy or laboratory findings. Distinctive signs include skin depigmentation, nail dystrophy. Grading system used is according to NIH consensus criteria. First-line treatment is corticosteroid. Second-line treatment includes thalidomide, ECP, mycophenolate, pentostatin, rituximab. Finally, patients who have been cured of their disease may have long-term sequelae from the conditioning regimen, GVHD or its treatment. Examples are such as endocrine complications like infertility, hypothyroidism, adrenal insufficiency. Secondary malignancies may occur such as skin cancer and post-transplant lymphoproliferative disease. These complications are an important cause of morbidity, and patients need to be regularly followed up for screening or prevention and treatment of these late complications.